The steps of frontalis sling, I'll show it with an oral sling. And the classical indications of frontalis sling are bilateral severe congenital ptosis with poor LPS action. It's very important to take a special consent for the lid lag, which inevitably happens postoperatively, and lag of thalamus, which can lead to corneal exposure and risk of undercorrection. Very important is marking of the sling. A lid crease incision is marked in symmetry with the other side. Two supratarsal 2 millimeter incisions are given just at the level of the medial limbus and the lateral limbus. Then two incisions above the brow, which are just lateral to these two tarsal incisions. And the third one is in the center of these two incisions and about a centimeter above these suprabrow incisions. And this is how the sling will be passed, ultimately causing a pentagon. And this helps the lid to be elevated with the help of the frontalis sling, because the levator is absolutely non-functional. This is a surgical video, and we do the markings as discussed. First of all, 350 silk sutures are passed to stabilize the lid and apply traction. After this, a lid plate just smeared with a little bit of ointment is inserted. A lid crease incision is made with the radio frequency knife, and we excise a small strip of skin in orbicularis so as to avoid a post-op bunched up appearance. And after this, the brow incisions are being made. These are made up to the level of the periosteum. There is brisk bleeding, but it is controlled with pressure. Needless to say that we should have adrenaline in the block. The tunnels are being made between the brow incisions to allow easy passage of the sling. These are the two tunnels between the three suprabrow incisions. And then we also make tunnels from the brow incision up to the lid crease incision. And this takes a little bit of doing. And after this, we start inserting the sling. We start from the lid crease incision laterally. From the lid crease incision onto the tarsal incision, which I've made. The needle is slightly rounded for easy insertion. Then from the lateral to the medial incision above the lid margin, and then back onto the lid crease incision. The lid crease incision helps in proper placement of the sling. And now we are seeing that the sling has not gone full thickness into the lid. So the lid crease incision helps you with the proper depth of placement of the silicone sling. Because if it is very superficial, it is going to get exposed postoperatively. Now, both the ends are coming out of the highest central incision. After this, the two ends come out are passed through a silicone sleeve, which comes with the sling, and the whole thing is tightened. Usually, we keep the lid above the level of the upper limbus because the poor LPS action will cause some postoperative drooping. And then the incisions are closed. And the supratarsal incisions need not be closed, but the lid crease incision has to be closed by a running or interrupted suture. We also fixate the silicone sleeve to the two ends of the tube so as to avoid any post-op slippage. And this is a very important step. We are pushing the edges into a tunnel made on the upper side of this brow incision. Again, this helps in proper placement of the sling. If this is not done properly, it's very easy for the edges of the sling to be exposed post-operatively, and that will need removal of the sling. A frost suture is given so as to give corneal protection for a few days. And this is a post-op picture of a different patient. You can see the lid lag in down gaze, but in straight gaze, he looks reasonably good. Again, the complications of this surgery is under corrections because we're dealing with a poor LPS action. Infection of the sling, if it happens, usually necessitates removal, and a lid notch can happen if there's asymmetrical tightening of the sling. Thank you.